share his experience about the approach with the approach of the patient with suspect acute coronary syndrome, specifically with subtle findings in the electrogram. And I hope that with a new approach, Dr. Smith is gonna make some lessons to learn today. Dr. Smith, thank you again for accepting our invitation, and you can start wherever you want.
Thank you very much. So the title of today's talk is Let's Replace the STEMI Non-STEMI Paradigm with the Occlusion MI, OMI, versus Non-OMI, NOMI paradigm, and also artificial intelligence in the ECG diagnosis of OMI. Okay. So I have some financial relationships, and especially important is that I am a shareholder of Powerful Medical, which makes the artificial intelligence software, which I'm going to demonstrate here. I'm from Hennepin County Medical Center, Emergency Medicine. We've been here for 37 years. We have a fantastic residency program, and I owe a lot to all my colleagues who inspire me every day to do good research and clinical medicine. So here's an example case. A 60-year-old has sudden onset of epigastric pain radiating to the chest, and he has this electrocardiogram. And this is a hyperacute T wave here. It is all but diagnostic of an acute LAD occlusion. There's also an old inferior MI with Q waves here, but this is the important thing today. This was not seen by the clinicians. It was sent to me later, texted to me, and I responded acute LAD occlusion. The first troponin I came back negative, which is very common in acute coronary occlusion. In fact, at least 25% of acute coronary occlusion have a negative initial troponin. And they did not see this, so they did not activate the cath lab. The troponins rose, and the patient went to the cath lab at 6 hours. There was 100% LAD occlusion. The peak troponin was greater than 25,000, and the patient ended up with an ejection fraction of 35% and new heart failure. What was the diagnosis? NSTEMI. What a worthless diagnosis. The patient loses half his heart, and he gets a diagnosis of NSTEMI. And in fact, later, his baseline EKG was found, and you can see this is a normal T wave, and this is a hyperacute T wave. All right, big difference. So timeline of OMI, NOMI. I wrote this book in 2002, the ECG and acute MI. In 2008, I started Dr. Smith's ECG blog, which now has 1,700 posts on it and thousands of EKGs, and most of the posts are about subtle coronary occlusion. Then I started giving a talk called Non-STEMI that need the cath lab now. In 2014, I changed it to the false STEMI, non-STEMI dichotomy. And then we realized we need a new name for acute coronary occlusion myocardial infarction, or ACOMI, and I did a Twitter poll, should it be ACOMI or OMI? And the overwhelming response was it should be OMI, occlusion myocardial infarction versus non-occlusion myocardial infarction. Occlusion myocardial infarction is the coronary artery is occluded regardless of whether there is ST elevation or not. OMI, NOMI. So in 2018, we wrote the OMI manifesto, and here you can see Martin Luther posting up an EKG with hyperacute T waves on the cathedral door. So I started giving this talk, let's replace the STEMI non-STEMI paradigm with the OMI NOMI paradigm. And I gave the keynote Rylant lecture at the 2021 annual meeting of the International Society of Electrocardiology. ST elevation, it's a supposed surrogate for acute coronary occlusion, but this is just conventional wisdom. It's dogma. Where does the data come from? It comes from the FTT meta-analysis published in Lancet in 1994. They did a meta-analysis of 9 studies, all 9 studies which enrolled at least 1,000 patients, and this amounted to 58,000 patients in the placebo-controlled thrombolytic trials of the 1980s. Who did they enroll? Patients with suspected MI. Only 4 of 9 required ST elevation, and it was very poorly defined. 5 out of 9 trials did not require any ECG findings for enrollment. No trial specified the method of ST measurement. 38% had greater than 6 hours of chest discomfort. They used streptokinase in 7 out of 9 trials. Results? If ST elevation is present, mortality is lower. If ST depression, mortality is higher. If left bundle branch block, mortality is lower. This is all the data you have to say that the STEMI paradigm is worthwhile. Their conclusion, ST elevation is the best way to decide on reperfusion therapy, is only true if your ECG interpretation is crude, you're treating with streptokinase, and your treatment is delayed. The ST elevation criteria in use today, which are used in the 4th Universal Definition of MI, was published by Peter McFarland in 2004. there were 1,220 patients, 248 with myocardial infarction by CKMB. This was from a 1980s cohort. It was not an angiographic study. They looked at 2 consecutive leads with ST elevation and found that 1 millimeter in all leads except V2 and V3 was the best diagnostic cutoff. These are measured at the J point relative to the PQ junction or the QRS onset. And in V2 and V3, women required 1.5 millimeters, men over age 42 millimeters, and men under age 42.5 millimeters. This was 46% sensitive for MI by CKMB. This would be much lower by troponin and 98% specific. We need to consider less obvious ST elevation, ST depression, its location, number of leads, and rapid treatment, hyperacute T waves, STT morphology, the entire QRS, including terminal QRS distortion, associated Q waves, and especially important is proportionality, ratios of STT to QRS amplitudes. In left bone mass block and paste rhythm, we can't just say all of them are eligible for reperfusion. We have to figure out which ones are occluded and which are not. And then there's pseudo-STEMI patterns and mimics. How do we identify those? Paradigms, cognitive frameworks which influence us. The name STEMI leads to cognitive bias. Reframing is necessary. STEMI makes you think the ST segments are all that matter. What really matters? Acute coronary occlusion without collateral circulation. Myocardium is at imminent risk of irreversible infarction, and if recognized early, the myocardium remains viable and salvageable with reperfusion. And so in the STEMI non-STEMI paradigm, we have what's called the no false negative paradox. If the ECG meets ST elevation criteria and the angiogram shows acute coronary occlusion, it's a true positive. If there's no angiographic evidence of occlusion, it's a false positive. If the ECG does not meet ST elevation criteria and there is no evidence of occlusion, it's a true negative. But if there's no ST elevation and there is acute coronary occlusion, it is a non-STEMI. It is not a STEMI because there's no ST elevation. Therefore, there is no false negative test for a STEMI. No false negative. The test is the definition, ST elevation. Now, I don't know of any other pathology in medicine in which the test is the definition of the disease. Can you think of any? This is like saying that rather than saying appendicitis, we say a high white count abdominal pain, where the white blood cell count is neither sensitive nor specific. You would never call a pathology by its test, but here we actually do that. In OMI, NOMI, the state of the artery, occlusion or not, is the definition. Now, this no false negative paradox plays out in all the research on STEMI, on the EKG in STEMI. All the research is done on registries of STEMI, and the registries of STEMI only include patients with STEMI. They do not include patients who have OMI that is not a STEMI. And so you can't do accurate research on OMI with STEMI databases. So here's a study from way back in 2002 by Koyama, immediate angiography and PCI for all suspected STEMI and non-STEMI. So non-STEMI with persistent ischemic symptoms and or ECG ischemia were taken. They had to have non-diagnostic ST elevation. In STEMI, 50% had TIMI zero flow, 100% occluded. And we know this is typical that many STEMI do not have complete occlusion because by the time they get to the cath lab, the artery is open. In non-STEMI, 47% had TIMI zero flow, very little difference. The mortality was 5% in both groups. So way back in 2002, we knew that STEMI and non-STEMI are not that different. Conclusion, non-STEMI with occlusion, STEMI negative OMI we call that, are equivalent to STEMI. And then in 2017, Kahn published Impact of Total Occlusion of the Culprit Artery in Acute Non-ST Elevation Myocardial Infarction, Systematic Review and Meta-Analysis. They looked at 40,000 non-STEMI. These were patients who were enrolled in clinical trials. 10,000 had total occlusion on next-day angiogram. The mortality of the N-STEMI OMI group was double that of N-STEMI with an open artery, in spite of the fact that the N-STEMI OMI were 15 years younger and had fewer comorbidities. The biomarkers were higher and the LV function was worse. And there's several later studies that confirm that by Terlecki, Abusharek, and Herman. Meta-analysis in 2024 with 23,000 patients showed that this year, the sensitivity of STEMI criteria for OMI is only 43%. That is a terrible test. And yet we name the pathology after the test. But what's the reality? Here's another reality. This study was not included in the meta-analysis, prospective validation of current quantitative electrocardiographic criteria for ST elevation myocardial infarction. These authors found that the computer using STEMI criteria on the first ECG was only 21% sensitive for OMI. On serial ECGs, 30% sensitive for OMI. A blinded cardiologist with visual ECG interpretation was only 49% sensitive for these 136 OMI. The most common objection, number one, to the OMI-NOMI is that refractory ischemia is already in the guidelines and thus already in the STEMI paradigm. Well, this is true. The ACC guidelines and the European guidelines do recommend this. However, these guidelines are not followed. This article in Clinical Cardiology 2022 by Lupu et al. Showed that of 156 patients were very high risk, but only 10 of these, or 6.4%, underwent immediate coronary angiography as indicated by guidelines. Most common objection number two, NSTEMI trials of early versus delayed cath did not show any difference in outcomes. Now, anybody who says this has not read these studies thoroughly. The biggest of these studies was the TIMAX trial, Timing of Intervention in ACS, by Mehta in the New England Journal in 2009. Non-STEMI were randomized to early or routine PCI. The results? No difference in death, MI, or stroke. Oh, there's no difference. We don't need to worry about NSTEMI. But early intervention was not early. If you read the article and actually look at it, the median time to intervention was 16 hours. If you have an acutely occluded coronary artery without collateral circulation, by 16 hours, all that myocardium is dead, and you won't find any difference between a 16-hour and 52-hour intervention. Also, they excluded patients with refractory pain. In fact, even with these two caveats, the GRACE score, patients with a GRACE score greater than 140 did have significantly better outcomes with earlier intervention. Also, 20% of these patients were unstable angina. The troponins were negative. Of those with an acute MI, the hazard ratio was nearly statistically significant. RCTs, non-STEMI, early PCI versus next day PCI. There are a whole bunch of them. RCTs, which enrolled patients who were chest pain free and or early was defined as 5 to 16 hours from presentation, showed no significant difference. However, all RCTs, which enrolled patients with active chest pain and early intervention was defined as less than 2 hours, were positive. In other words, early intervention produced better outcomes. So don't let people tell you that it's been proven that non-STEMI don't need to go to the cath lab emergently. They often do, but which ones do? How about mortality of NSTEMI with OMI? We studied this in a group from Aalst, Belgium, and you can see that this is the NSTEMI NOMI group. They have an open artery. This is STEMI, and they have slightly higher 12-month mortality. And this is the NSTEMI OMI group. They have quite high 12-month mortality, much higher than STEMI. They both have occluded arteries. Why would one have a worse outcome than the other? And the clear difference, well, and let's go to 60 months. Now it's much, much worse. Here's STEMI. Here's NSTEMI OMI with a hazard ratio of 2.59, much worse outcomes. And why is that? Because the STEMI get their artery opened in a median of 1.4 hours. The NSTEMI OMI have to wait 16.3 hours. So they have much higher mortality. And NSTEMI NOMI go in a median of 45.8 hours, but that's okay. Their artery is open. They no longer have active myocardium that's dying. What's the scope of the problem? There are 125,000 NSTEMI OMI per year in the US. About 30% of all OMI are missed using the STEMI paradigm. The NSTEMI OMI excess mortality over STEMI at 1 year is about 8.2%. At 5 years, about 17.3%. Hazard ratio 2.59. 8.2% is 10,000 excess deaths per year in the US. 17.3% is 21,000 excess deaths at 5 years in the US alone. And lots of heart failure suffering. So if you go to my blog, Dr. Smith's ECG blog, you can find the OMI literature timeline here. And you can see that in 2021, there were 16 articles published on OMI-NOMI. And so quite accepted. Of the 16 articles, 11 were by me and my research partner, Pendle Myers, and co-authors. It's very accepted in emergency medicine now. There were 12 articles in cardiology journals. 9 were by me and co-authors. And these are all the cardiology journals that they were published in. In 2022 and 2023, we're up to, I think, 48 or 50 some articles on OMI. And you can see they come from many countries. Here's one from Germany by Abusharek. And that's called acute coronary occlusion with versus without ST elevation impact on procedural outcomes and long-term all-cause mortality. How about Poland? Occlusive myocardial infarction, emerging paradigm of acute coronary syndromes. From Spain, acute coronary occlusion and non-STEMI. If you change the way you look at things, the things you look at change. United States, the 2022 American College of Cardiology Expert Consensus, which I'll talk more about. The United Kingdom of Greece, total coronary occlusion and non-ST elevation myocardial infarction. Time to change our practice? In circulation of occlusions, inclusions, and exclusions from India. How about from STEMI to occlusion MI from Canada and the United States? The STEMI non-STEMI dichotomy needs to be replaced by occlusion MI versus non-occlusion MI from Turkey and the US. From Brazil, just published this week, Beyond STEMI and STEMI Paradigm, the proposal for occlusion myocardial infarction diagnosis. This is in the archives of the Brazilian cardiology. The American College of Cardiology 2022 chest pain guidelines now recognize OMI. And in this section, they say the application of STEMI ECG criteria on a standard 12-lead ECG alone will miss a significant minority of patients who have acute coronary occlusion. And they have reference 21 here. Therefore, the ECG should be closely examined for subtle changes that may represent initial ECG signs of vessel occlusion, such as hyperacute T waves or ST elevation less than 1 millimeter. And 21 is our article, which is comparison of the STEMI, non-STEMI, and OMI, NOMI paradigms of acute MI. And in that study, we have this this figure. This is peak contemporary troponin, and it's a good measure of infarct size. Here we have all OMI. This is STEMI positive OMI. This is STEMI negative OMI, or N-STEMI that have an occluded artery. Their infarct size is about the same as STEMI, and you put the two together, and they comprise this entire group. Non-STEMI is this group. Non-STEMI is comprised of those with an open artery, which all have tiny infarcts, and those with an open artery, with a closed artery, excuse me. These two groups get lumped together into this group. That is absurd that these two groups get lumped into this group. This group has much higher mortality, much worse, much higher biomarkers, worse LV function. It's much more similar to STEMI. So let's have OMI, NOMI, okay? The ACC guidelines mention 5 STEMI equivalents, hyperacute T waves and posterior OMI, but they give no guidance on how to diagnose them. They also mention De Winter T waves, and they mention the Smith modified Scarbosa criteria for left bundle match block. That's the criteria I developed, and the Smith modified Scarbosa criteria for ventricular paced rhythm. So we looked at the accuracy of OMI ECG. Your free meeting will end in 10 minutes. What's that mean? I hope it doesn't end. Accuracy of OMI ECG findings versus STEMI criteria for diagnosis of acute coronary occlusion myocardial infarction. And we looked at 808 cases of high risk possible ACS, and the ECG diagnosis of OMI by an expert, me, versus STEMI criteria. My sensitivity for OMI was 86% versus 41% for STEMI criteria. Specificity was equal. Accuracy was much higher for OMI criteria as measured by an expert. There were 7 findings among 146 OMI patients, which were identified earlier by me than by STEMI criteria or angiogram. They were hyperacute T waves, pathologic Q waves, along with subtle ST elevation, terminal QRS distortion, reciprocal ST depression and or reciprocal T wave inversion, subtle ST elevation not meeting criteria, but with other features, any amount of ST depression maximal in V1 to V4, any ST elevation inferior leads with any ST depression or T wave inversion in AVL. If there's one ECG principle to remember, it is proportionality. T waves and ST elevation are only large or small relative to the QRS. So here's a patient who is 40-some-year-old woman with chest pain, and she has a little bit of ST elevation V2. It does not meet criteria, and that does not meet criteria, and that does not meet criteria. But look how small the QRS is. It's tiny. How can you evaluate ST elevation in a patient with hardly any QRS amplitude? So let's stretch it out so that there's some decent amplitude in here. And you can see there's massive ST elevation when you do that. Everything is relative. And back in 2012, I derived and validated a rule to diagnose LAD occlusion versus normal ST elevation. And I don't have time to go into that rule, but it involved measuring the corrected QT interval, ST elevation at 60 milliseconds after the J point and lead V3, the R wave amplitude in lead V4, and the total QRS amplitude in lead V2. The smaller this R wave and this QRS amplitude are, the more likely it is to be OMI. And that was all put into the formula, which turned out to be extremely accurate in making this diagnosis. All because ST elevation is only one of 4 measurements that go into it. So I'm going to tell you about our AI algorithm, and the AI algorithm, when looking at this EKG, diagnoses OMI with high confidence. The major learning point here is only approximately 1/3 of OMI are STEMI, and they are missed. ECG diagnosis of STEMI negative OMI is often extremely difficult. Serial ECGs that eventually meet STEMI criteria are recognized earlier by OMI findings, like hyperacute T waves. It is learnable to some degree with hard work, practice, and repetition, but it is very difficult even for those who work hard. Artificial intelligence and deep convolutional neural networks are the answer, I believe. Non-occlusion myocardial infarction deserves some mention. Non-OMI or NOMI, most have a culprit with ulcerated plaque. There is no active ischemia, no active chest pain, no persistent ECG ischemia. They eventually need intervention within 24 to 40 hours, but they don't need it emergently. The ECGs either show reperfusion or they are nonspecific and extremely insensitive, and even experts like me and Dr. Myers cannot reliably diagnose these. But we don't need to diagnose them on the EKG because they don't need to go emergently. You need troponin to make that diagnosis, but you can wait for troponin in these cases. Then we got to get on false positives. What's the false positive rate for the STEMI criteria? There are 4 studies that looked at it: Contos, Larson, McCabe, and Garvey. Which of these is accurate? It's actually 15 to 30%. So I gave the annual keynote Kenichi Harumi address to the International Society of Computers and Electrocardiology in 2022. And the title of it was, "What should artificial intelligence focus on?" The diagnosis of acute coronary occlusion. All these computer experts had been spending all their effort on diagnosing atrial fibrillation. I find the diagnosis of acute coronary occlusion is far more important. And so I showed them these photos. Everybody knows that this is Barack Obama and this is his impersonator. But can you find criteria that will tell you that? You look at the length of his nose, they're the same, size of the ears is the same, size of the smile is the same. Every measurement, excuse me, every measurement is identical, but you know which is which. And artificial intelligence can do the same thing. Artificial intelligence can recognize that this is Barack Obama and that this is not Barack Obama. And the other thing, so I told them, we have to use artificial intelligence. Looking at an EKG is like looking at a face to me, and I can recognize that face like artificial intelligence. The other thing I told this group is that you have to be able to digitize images. There are so many images available which an artificial intelligence system can learn from if it knows which is OMI and which is not OMI. But in order to do that, it has to take an image and make it into a digital file which can be analyzed by AI. AI can only analyze XML files. It cannot analyze JPEGs or PNGs. Well, these computer scientists at this conference said it's impossible. You cannot possibly digitize a JPEG or a PNG or a PDF into an XML file. Well, it turns out that there was a company who could do it. So in 2023, spring of 2023, I got together with Dr. Al-Zaiti. He had written machine learning for ECG diagnosis of myocardial infarction, and it wasn't working very well. And the reason it wasn't working very well is he's trying to diagnose any kind of MI by it, and it's not, you can't diagnose non-OMI by the EKG with any kind of accuracy. So I suggested that he concentrate on OMI, occlusion MI, and that's what he studied. He published this in Nature Medicine, and he found that this ECG smart system, AI, was far better than clinical experts or a commercial ECG system. This is the area under the curve. This is sensitivity graphed against 1 minus specificity. A perfect test is right up here. The closer this line gets up to here, the better the test. So this was quite good and published in Nature Medicine for diagnosis of OMI, but not for diagnosis of any MI. And then Powerful Medical came to me and said, we can digitize an EKG. And if you can train our system to diagnose OMI, then we will have a great system. So they can take this EKG, which is all crumpled up, and they take a photo of it with a smartphone and turn it into, that's the input image, and they turn it into a digital ECG waveform. This is now an XML file, which can be managed by AI. And so we taught their system, and we call it the Queen of Hearts, and the Queen's verdict on this case, go back to that. This has some subtle ST elevation here with reciprocal ST depression here, diagnostic of OMI, and the Queen of Hearts sees that ST depression in AVL, that hyperacute T wave in lead 3, and diagnoses OMI with high confidence. So version 1, we trained it on 4,000 OMI and 14,000 without OMI, and we published in the European Heart Journal Digital Health. And the OMI outcome definition was TIMI 0 1 flow or TIMI 2 to 3 with urgent PCI. And this is the AUC here, which is very good, 0.94. This is me right here, right on that curve. This is a STEMI criteria, very bad STEMI criteria, very insensitive. And in fact, at a fixed specificity of 97.7%, the AI model had 66% sensitivity versus 32.5% for the STEMI criteria, double the sensitivity at the same specificity. And time to diagnosis, OMI AI model, 2.3 hours, STEMI criteria, 5.3 hours. So much faster reperfusion. This is an example of a missed OMI from the Al-Zaiti paper. In other words, the Al-Zaiti algorithm did not diagnose this. Now, I can tell you right now, these are hyperacute T waves here. They are far too big for that tiny QRS. And I was wondering how the PM Cardio Queen of Hearts would work on this. So I submitted it to the Queen of Hearts, and this Queen of Hearts gets OMI with mid-confidence on this EKG. And we have explainability on the Queen of Hearts, which shows you it's looking at that hyperacute T wave. OMI high confidence in lead V2 resulted in OMI mid-confidence overall for the entire EKG. So this Queen of Hearts has been implemented at the hospital in Aalst, Belgium. They looked at atraumatic chest pain patients presenting to Aalst STEMI network from January 1, 2024 to March 16, 2024, 2.5 months. There were 731 patients. 589 were excluded because cardiology was not consulted, there was no ECG available or inconclusive outcome. Patient was hospitalized or consulted with cardiology, N equals 142. 65 had no ACS, 54 had NOMI, and these are bundled together. So this is an MI here, but it's not an occlusion MI. And these are bundled together collectively, not OMI. And then there are 23 OMI. All right, so this was implemented in Aalst, Belgium. And since implementation, there were 23 OMIs. 12 of them were STEMI, and the median time to reperfusion, 1.2 hours. For the NSTEMI OMI, which are 11, the median time to reperfusion was 1.47 hours. For the NSTEMI NOMI, we're not occluded, it's at 19 hours. Now look at that compared to historical. STEMI were 1.4 hours before, that's comparable. But NSTEMI OMI, previously, median time to reperfusion was 16.3 hours before the use of Queen of Hearts. Since the use of Queen of Hearts, NSTEMI OMI median time to reperfusion is 1.47 hours. There were 6 false positives. 1 was Takotsubo, 1 was myocarditis, and for 4, the history did not fit and the physician canceled. The symptoms were not acute and the patient, one patient was post-recent PCI. So let's go back to that first case that I told you about, a 60-year-old with sudden epigastric pain radiating to the chest. And these are hyperacute T waves. And I said this was an acute LAD occlusion without any other information. The first troponin was negative. And troponins rose. The cath lab was activated 6 hours. There was 100% LAD occlusion. The peak troponin was greater than 25,000, and the patient ended up with 35% ejection fraction and new heart failure. And if we send that one to the Queen of Hearts, she gets OMI with high confidence. We don't miss it. And there you have explainability, looking at hyperacute T waves here and here. So now we do not have a diagnosis of NSTEMI, we have a diagnosis of OMI, and we go to the cath lab quickly, we get the artery open, and the patient does not end up with heart failure. So I'm going to show you some more cases. This was texted to me while I was in a meeting, 46-year-old with chest pain. And I looked at this and I said, well, there's a little bit of ST depression here and here and here. That should never be there. And then it goes along with a little bit of high lateral ST elevation with inferior ST depression. These are reciprocal each other. This is a high lateral and posterior OMI. So I texted back, activate the cath lab. And they did. It was a posterior lateral OMI with an obtuse marginal occlusion and a very high troponin. I send this to the Queen of Hearts and she sees it, OMI with high confidence. And I don't have the explainability map on this one. Here's another case. This was an intern, a first-year emergency medicine trainee who saw this patient with chest pain and saw this EKG, and he knew immediately that these were hyperacute T waves because they are too symmetric, and the R wave regresses from here to here. That shouldn't happen. And so he activated the cath lab. And sure enough, the LAD was occluded. Here it's occluded. Now a wire gets put through it, and then it gets opened up all the way. And if you send this one to the Queen of Hearts, she knows it's an OMI with high confidence. And here the explainability map shows that she can see these are hyperacute T waves. How about this one? Lots of ST elevation everywhere. Patient has chest pain. What do you think? Oh, must be a STEMI, right? Well, in fact, there's so much R wave amplitude here and very prominent J waves that I can tell that this is a fake, a mimic. It is not an OMI. And if you send it to the Queen of Hearts, she knows it is not OMI with high confidence. And this patient ruled out by serial troponins. And you can see in the explainability map, she sees lots of R wave amplitude. She looks at not just at ST elevation, she looks at the R wave, the Q wave, she looks at the T wave, she looks at everything. Here's a case that was handed to my research partner, Pendle, while he was working in the emergency department in triage. He sees this EKG. Take a look at that. That ST segment is very straight. That T wave is too big for that tiny QRS. So he thought, he didn't know anything about this patient. He thought this looked like like an OMI, an LAD occlusion, if the patient has chest pain. He went to talk to the patient. Sure enough, she has acute chest pain. And then he found an old EKG, and there you can see it does not have that hyperacute T wave. And here you can compare them side by side. And he activated the cath lab. Oh, by the way, the Queen of Hearts says OMI with high confidence. This is incredible that she can see these hyperacute T waves and know that it's an occlusion myocardial infarction with high confidence. Patient went to the cath lab, and you can see the LAD is occluded right there, and it gets opened up by percutaneous coronary intervention. Here are two patients, both presenting with acute chest pain. Are they OMI? Are they not OMI? Which is? Both? Neither? You can see they look very similar. There's a little bit of ST elevation AVL here and here. There's ST depression 3 here and here. There's a little bit of ST elevation 1 here and here. What's the difference between these two? They're very difficult to tell the difference. I can tell that this one is an OMI and this one is not an OMI. Can the Queen tell the difference? Sure enough, she sees OMI with high confidence up here. And she sees not OMI with high confidence here. And she was correct. This one was an OMI and this one was not an OMI. And this is the explainability map. She sees that negative hyperacute T wave there, positive hyperacute T wave there, negative hyperacute T wave there, and she sees nothing in the other one. And so she comes up with OMI high confidence on that top one and not OMI high confidence on the other one. I saw this EKG when I was reading through the system, and I said, oh, look at that. There's an inferior OMI, some subtle ST elevation 3, reciprocal depression and AVL, a flat ST segment with a little depression in V2. So it's an inferior posterior OMI, ST depression in V3 as well, V4, V5. So I went in to see the chart, and I noticed that the patient had not had the cath lab activated. It was too late, and the patient suffered a large myocardial infarction. And this was after 100 minutes of chest pain. And if you send this one to the Queen, she gets OMI with high confidence. It's incredible how accurate she can be. And the explainability map shows she's really looking at that ST depression in AVL and the ST elevation in lead 3 and looking at lead V2 as well. Here's a 60-year-old with acute chest pain. I saw this patient in the ED, and there's ST depression in V2 and V3. Any ST depression of any amount, we published a paper in the Journal of the American Heart Association showing 97% specificity for OMI in a patient with acute chest pain who has any ST depression in that's maximal in V1 to V4 versus V5, V6. So this is diagnostic of OMI. So I activated the cath lab, and the cardiology fellow came down to the cath lab and came down to the emergency department, I'm sorry, and said, that's not a STEMI. And I said, you're right, it's not a STEMI, it's an OMI. And then after 37 minutes, we were waiting for the cath team to come in. And at 37 minutes later, we got another EKG. And now you can see that they're hyperacute T waves in V5, V6. Let me go back to the previous one. Flat ST segment, normal T waves. There's a little bit of ST elevation in V6, which is very suspicious as well. But now 37 minutes later, these are hyperacute T waves. This has got more ST elevation, hyperacute T wave. And if you compare them, you can see these T waves got much bigger and fatter. What is a hyperacute T wave? It is fat. It is not tall. This is no taller than that. It's much fatter though. Longer QT interval, straighter ST segment, has much more bulk to it than this one. A hyperacute T wave has to do with its bulk, its overall fatness, not its height. And so patient went to the cath lab. There was 100% first diagonal occlusion. The peak troponin was greater than 50,000. This was a huge myocardial infarction, and all it shows up as a little ST depression here. And if you send that one to the queen, she gets OMI with high confidence. This is the one without the hyperacute T waves in V5, V6. I just sent the first one, which was much more subtle. And the explainability map shows that what she's looking at is the ST depression here, which is down sloping. And she's also looking at that little bit of ST elevation in V6. This was texted to me one Saturday evening when I was at home. Queen says not OMI with low confidence. And I looked at this, these are very suspicious T waves for an acute LAD occlusion. And then I saw that part of the EKG is cut off. So I went into our computer system to find the patient, and I found the patient and got the whole EKG, which includes leads 1, 2, and 3. You can see they're cut off in this photo. So when you take a photo of the EKG, you have to take a photo of the entire EKG. Now I took the entire EKG and I sent it to the queen, and she gets OMI with high confidence here. And sure enough, it was an LAD occlusion. This patient came into the emergency department with chest discomfort. How am I doing on time, by the way? Okay, it looks like chest discomfort has hyperacute T waves in V2 and V3 and V4. These don't look very big, do they? But look how small the QRS is. It's all got to do with proportions. So this is diagnostic of an LAD occlusion. And the emergency department activated the cath lab. It was during the daytime, so 5 cardiologists came to the ED and said, it's not a STEMI. And it's not a STEMI, it's an OMI. Cath lab was canceled. Patient ruled in by rising troponins, went to the cath lab too late, had 100% LAD occlusion, very large MI with much myocardial loss, but it was not a false negative. The final diagnosis was non-STEMI. Again, that worthless diagnosis of non-STEMI. The formula I was telling you about that differentiates between the ST elevation of LAD occlusion and normal ST elevation was a high value. It was 18.53 to 19.57, and greater than 18.2 is likely LAD OMI. And sure enough, that was. And so you send it to the Queen of Hearts. She gets OMI with high confidence for that EKG. Now, AI also reduces false positives. At our hospital, we looked at 117 pre-hospital cath lab activations by medics. 48 of them turned out to be true positive OMI, 69 false positive activations. So the STEMI criteria missed 15 of those 48 OMI and had 11 false positives. The algorithm that was used on the device, on the pre-hospital EKG system, the conventional algorithm, missed 1 of 48 OMI, but had 42 false positives. Expert, that was me, I missed 2 of the 48 OMI, but only had 9 false positives. The Queen of Hearts missed none of the 48 OMI, but had 29 false positives. And then there's when the EKG the pre-hospital EKG cuts the S wave off, which makes it hard for the Queen of Hearts to make the diagnosis. When we exclude cases where the S wave is cut off, she misses 0 OMI and only has 16 false positives. So it reduces false positives and it detects very subtle OMI. Here's a patient with chest pain who has massive ST elevation here and here. Most people would be worried about this. I can tell it's a fake. It's a mimic. It is not an OMI. It's a combination of what we call benign T-wave inversion, early repolarization, and LVH. Sure enough, the angiogram was normal. Patient ruled out by serial troponins, and the Queen of Hearts gets not OMI with high confidence. You can get access to the Queen of Hearts for free. You can try it out on your own, see what you think. use your phone on this. And then I'm going to go ahead and show you some more cases. And if you fail to get that onto your phone, you can go to my blog, just type in EKG blog into Google and you'll get my blog. And there are many blog posts which have a link to getting the Queen of Hearts for free. So this is a 30-year-old woman with a heart score of 0. She comes in with chest pain. She has a heart score of 0. Her emergency department assessment of chest pain score is only 2, which is like a heart score of 0. The computer says the EKG is completely normal, and the first troponin is undetectable. This is her EKG, which the conventional algorithm said was completely normal. Now I can tell you this is a hyperacute T wave, and this is a negative hyperacute T wave. This is diagnostic of inferior OMI. And it's also some downsloping ST segment in lead V2. This is an inferior posterior OMI. But none of the conventional ways of diagnosing myocardial infarction find it. But the Queen of Hearts diagnoses OMI with mid-confidence. And then she got a serial EKG that shows a little, now there's some ST depression in AVL. There's more of a hyperacute T wave, a different kind of hyperacute T wave in lead 3, 2, 3 in AVF. And you put these side by side. Here was the first one. This is what the T waves look like in 2, 3 in AVF. Now they look different, but they're still hyperacute. Hyperacute AVL looks like this here, looks like this here. This was a third EKG, which still looks like OMI, but it's very dynamic. And that one also, the Queen gets OMI with high confidence. And you put them, and even V4 to V5, V4 to V6 in both EKGs is dynamic. See how these T waves become more hyperacute, and she makes the diagnosis. So I have a collection of OMIs that the conventional algorithm calls completely normal. Like, it doesn't say they're non-specific. It says they're completely normal. And there are 3 papers that state if the conventional algorithm says the EKG is completely normal, they don't need to be reviewed by physicians. Well, I have 51 cases of these where it was an acute occlusion and the conventional computer algorithm called it completely normal. And these are algorithms by Veritas, General Electric, Marquette 12SL. The Queen of Hearts diagnosed all 51 as abnormal and diagnosed 38 of them as OMI. So here's a 60-year-old with chest discomfort and has this EKG with a hyperacute T wave in lead V4 and lead V3. Look how small the QRS is, how big the T wave is. Well, that was not seen. So she was put in the waiting room. And at 37 minutes, they thought, well, we should get another EKG, which is a good idea. They should. And they got another one, and it still just shows hyperacute T waves. So they left her in the waiting room where she had a cardiac arrest. Now, she was lucky she had a cardiac arrest. Why was she lucky? Because that gets their attention. When she had a cardiac arrest, she could be defibrillated and resuscitated, and then she could get her artery open. There's her LAD completely occluded, and now it's getting opened up. Now it's fully open. Had she not had a cardiac arrest, she would have lost half her heart, and she would have been a cardiac cripple. But instead, she was lucky she had a cardiac arrest. Now, if they'd used the Queen of Hearts on that first EKG, it would have diagnosed OMI with high confidence, and she would have gotten her artery opened before she had a cardiac arrest and before she had more myocardial damage. And there you can see the Queen of Hearts looks at part of the T wave and the ST segment and gets OMI with high confidence. So I was lying in bed one night. One of my former residents texted me this EKG in the middle of the night, 60-year-old with classic chest pain. The cath lab is occupied for the next 90 minutes. Cardiology says not a STEMI, thinking of giving lytics. And this was the EKG. Tiny little T waves, but massive compared to that tiny little QRS. Same here. These are hyperacute T waves because in proportion to the QRS, they're huge. And so I texted back, this is OMI. Did you give lytics? Proximal LAD occlusion. Great catch. And it turns out she had a baseline EKG, which I saw later. And there's the difference. See, there's nice R wave amplitude here, which is gone here. T waves are smaller here than here. So these are hyperacute. These are not hyperacute. Now he got another EKG 100 minutes later. Again, massive hyperacute T waves. That's a tiny QRS there. And again, compare it to the baseline. So I send these to the Queen of Hearts much later. Many years later, I sent the Queen of Hearts. And she diagnosed OMI with high confidence, and this one OMI with mid confidence. And the explainability map shows you why. And so this patient did get reperfusion. here's a 29-year-old with severe chest pain. And you can see that there's a lot of ST elevation, but he's a young guy, and young people have a lot of ST elevation. What they don't have is something I call terminal QRS distortion. Look in lead V3. There is no S wave here. There is no J wave. We showed that in all cases of normal variant ST elevation, there is always an S wave or a J wave. In V2, there's always an S wave. In V3, 90% of the time, there's an S wave. And in 10% of the time, there may not be an S wave, but there's a prominent J wave. This has neither. So this cannot be normal ST elevation. It was not recognized because they thought it was just normal ST elevation. And then the patient's chest pain went away and his EKG findings resolved from this to this. When they saw this, they knew, this must be LAD occlusion. This is spontaneous reperfusion. Now the artery's open. Now they're worried about the patient because they realized, his LAD was occluded here. So they went to the patient's bedside, and on their way to the patient's bedside, he had a cardiac arrest. He could not be resuscitated. He did go to the cath lab while CPR was in progress. They shot his LAD. His LAD was completely occluded, but they could not get it open or resuscitate it. So he died. Queen of Hearts, OMI with high confidence. And the explainability map. Felipe, you're gonna have to tell me when I should stop, okay? Because I got a lot more to do. Here's a 42-year-old male with complaints of burning from his epigastrium through his throat. He's otherwise healthy. It's relieved by Maalox and lidocaine. So they think it's gastroesophageal reflux. Here's his EKG. The computer algorithm says it's completely normal. The physician reads it as completely normal, but it is not normal. These T waves are too big for that tiny QRS. Same here, same here. Look at this one here. This is what the normal V4 to V6. Look at the difference in the size of the T wave there. And this is AVL magnified. You can see that's a massive T wave compared to that. Look here. So if you use my formula, it says that it's an LAD occlusion. And the patient, so the nurse was discharging the patient on some medication for reflux. And while he had a cardiac arrest in front of the nurse just before he could be discharged, they resuscitated him and then got this EKG, which shows a massive STEMI, proximal LAD occlusion. And I forgot, I didn't send that to this. If you do send this one to the Queen of Hearts, it says OMI with high confidence. I forgot to put that in there. 37-year-old woman with chest pain. She got no ST elevation at all, anywhere. Massive T wave though. This is diagnostic of LAD occlusion. Diagnostic. All troponins were normal. Patient was sent home and died. This ended up being transient. In a case review, 50% of physicians said it was normal. Now, when I see these things, I don't know if they're obvious to everyone or they're just obvious to me. I'm so used to seeing these things and recognizing them that I can't tell how hard they are. They must be very hard for humans to see because 50% of physicians said it was normal. But if you send it to the Queen of Hearts, she knows it's OMI with high confidence. And that's why. Massive hyperacute T waves all around. Here's I'm going to go through this one. It's just too hard. I saw this one in a queue of EKGs, and I saw this symmetric T wave with reverse R wave progression, and this massive T wave compared to the QRS, and down up T waves in 3 in AVF. And I knew immediately this was an LAD occlusion, and I thought this, I bet the physicians missed this. And so I went to the chart, and sure enough, patient had come in with chest pain. The first troponin was negative, and they didn't see this, and they admitted the patient to observation for chest pain. The second troponin returned to 4 hours at 3.8 nanograms per milliliter, and a repeat ECG was done, which showed QS waves here, massive myocardial loss. Went to the cath lab, LAD occlusion, peak troponin was 140 nanograms per milliliter, which is 140,000 nanograms per liter, permanent wall motion abnormality, permanent heart failure. And if you send this to the Queen of Hearts, OMI with high confidence, she sees these hyperacute T waves all over. This was recently texted to me from a former resident. Big T waves, big T waves. And I texted back, acute proximal LAD OMI. To me, it is obvious and diagnostic. He texted back, all my colleagues are amazed that I diagnosed this pretty obvious OMI immediately. I didn't think it was subtle at all, but they all say it is. And again, I can't tell now what's subtle and what's not, but the Queen of Hearts doesn't think it's subtle. She says OMI with high confidence. And the explainability map tells you why. And I think I should probably stop here for questions. What do you think, Felipe?
Yeah, sure, Dr. Smith. Thank you again. And we have an excellent speeches today. And I think there is a lot of questions here for some subtle aspect of the where you're speaking. I want to start with a question that some of the professors make to us, because we know that the artificial intelligence is growing up, but maybe the programs of the support to implement and to have an validated artificial intelligence maybe takes a lot of time. So they ask you, what is your opinion about to put the OMI concept into practice with these subtle findings in the electrocam, because maybe we don't have the opportunity to access to an artificial intelligence in this time. So what are your recommendations to our practice to implement these OMI concepts into a daily practice?
Yeah, well, the system is approved in Europe. And so, as I pointed out on one of my slides, in Aalst, Belgium, they are already using it, and they're getting their non-STEMI OMI to the cath lab in 1.4 hours on average. So they are using it. It's working very well. Now, it is not yet approved in the United States. The FDA, we have submitted to the FDA, and it'll be a while before we hear back. And I don't know about Colombia or any other country in South America. I don't know how that works, but anyone can use it on a trial basis. We have literally scores of hospitals around the world studying it and using it in a research capacity. And anyone who wants to get it and use it in a research capacity should contact me, and I'll get you in touch with the company representatives who can help you implement this at your hospital. Does that answer the question?
Yeah, sure. I think that we have a group very interested in this type of artificial intelligence, so it will be a good opportunity to them and for our to implement this type of technology in our practice. There is another question, Dr. Smith, because as we chose, maybe the guidelines that recognize today these subtle findings in the electrocam. Do you think that with this evidence, the next guidelines for acute coronary syndrome, this diagnostic recommendation will change?
Well, as I said, the American College of Cardiology now recognizes acute coronary occlusion without ST elevation as an indication for emergent cath lab activation. And they specifically mentioned hyperacute T waves and posterior MI, and also Smith modified Scarbussa criteria for left bundle branch block and for ventricular paced rhythm. So they already recognize this in the American College of Cardiology. In the European Heart, new guidelines acknowledge that ACS is a spectrum now, but they would not go ahead and change their name to occlusion myocardial infarction. And when I questioned them at the European Society of Cardiology conference last August in Amsterdam, they just came up with this lame excuse that it would be too confusing for people. So they do, both societies recommend emergent cath lab activation for ACS with persistent symptoms. So the problem is, which patients with persistent symptoms have gastroesophageal reflux and which patients with persistent symptoms have an acute coronary occlusion? How do you tell the difference? You need either a positive troponin, but the troponins won't help you for many hours. You can't tell if it's a non-OMI or an OMI, even if they are elevated. You have to have the EKG to tell the difference between persistent symptoms from gastroesophageal reflux and persistent symptoms from ACS. So that's why it's really essential to use the EKG and to have artificial intelligence to help you do it.
Thank you so much. There is another question, Dr. Smith, about the definition of hyperacute T wave, because as you show us, there are a lot of ways to try to define this change in the T wave. One is the area amplitude ratio, but as we know, this definition is so difficult to us for the simple visual aspect. So would you recommend other findings that help us to define those hyperacute T waves?
Yes. So I have long hypothesized that what makes me recognize a hyperacute T wave is mostly its area under the curve relative to the size of the QRS. Now, that's how I've taught this AI system. I was the one who taught this AI system. And so it kind of mimics my brain. And so now we have found a way of measuring the area under the curve on EKGs, and we have found a way of, and we are very close to submitting an article that shows that the area under the curve to the QRS size does indeed define hyperacute T waves. I don't have the entire results back yet, but we will be able to publish this fairly soon, and that will help. But it still won't be as good as using AI to recognize it. It's not. Let me also say, it is not the height of the T wave again. It's not. That's part of it, but there are three things which contribute to the area under the curve of the T wave. It's the height of the T wave, it's the QT interval, and it's the straightness of the ST segment it inflates the T wave to a large size. And then it always has to be in proportion to the QRS.
Thank you, Dr. Smith. As we have the 8 o'clock, and so we can finish with our session of today. Dr. Smith, thank you very much for your talk. On behalf of the university, we are very grateful for your participation and the time to share with us this experience and this new paradigm in the approach of the patient with acute chest pain. So thank you so much.
Thank you for inviting me. It looks like there's still one more question. Alejandro Hernandez Arango raised his hand. Is that?
Oh, sí,
okay,
Dr. Alejandro.
Thank you, but we'll have time. Don't worry. If we don't have time, we can finish.
I have time. I have time.
Dr.
Okay,
Alejandro, go ahead. Thank you.
Oh, thank you very much for the opportunity and for sharing your knowledge with us. Great talk. I have a question about if the Queen of Hearts algorithm has in their training Latin American patients, because those artificial intelligence systems that doesn't have patients with the race and ethnic with the correct race. Maybe the generalization of the algorithm could work in other way that we would expect. So the question here is about the generalization of the algorithm in other type of populations, and we are so interested in contacting you to perform a randomized controlled trials. So thank you very much.
Yeah. So the algorithm was taught based on a group of patients which partly come from my institution, Hennepin County Medical Center in Minneapolis, and a lot of them were African Americans, a lot of them were Latinos, a lot of them were white. So it was a diverse group, and it was also tested on a group from my hospital, so it was a diverse group as well. And the FDA had all these questions too, and we were able to answer them to their satisfaction. Now, it'd be much better if we had even more data from you guys, from Colombia. That would be fantastic if you wanted to study it in your population.
Thank you very much.
Thank you.
Yeah, we agree with that. Dr. Smith, thank you again for accepting our invitation. And that was our great speech today.
Thank you very much. Thanks for inviting me. Bye-bye.
Bye-bye. See you later.